A very good evening to all of you. Welcome to this much awaited annual event, which is the CCI World Asthma Day webinar. So, on this webinar, we try to inculcate the newer upgradations, the newer recommendations which Gina gives us, and at the same time, we also try to include a variety of opinions all across our great country and who are members of our CCI, so that we can really understand on a practical basis along with the technical basis as to where asthma, the disease which we as chest physicians consider something as very sacred. So we should be very well updated about the newer developments which are happening in its management and should give the benefit to our patients in the most rapid way possible. In order to have this very important and timely discussion, today I have with me truly a panel of which I myself as a moderator am very proud of. To introduce my panel, I would like to begin with none other than Dr. Nishtha Singh from Asthma Bhavan, Jaipur. Welcome, ma'am. Ma'am is a very renowned pulmonologist, and frankly, I don't think she needs any introduction. But I would really like to thank ma'am for being a part of this important webinar, and her insights will be very important onto what Gina is now asking us to do for our patients. Followed by that, I would like to introduce our webinar in charge, the guy who since World Asthma Day has been so busy all over the media, and I think he is already a part of 4 or 5 national webinars on GINA 2026. So Dr. C. Vijay Kumar sir, Dr. Vijay Kumar Chennamchetty sir, very thanks to you for agreeing to be a part of this webinar. I know you have been really overburdened with this whole asthma updates thing because of your great insight into asthma. Although today's webinar will be more on stable asthma, but still we'll be glad to have your inputs because I think that forms an important part of our day-to-day practice.
Thank you, Ravi.
Followed by that, right, sir, thank you. Followed by that, we have Dr. Rathi ma'am from Aligarh. Welcome, ma'am. Ma'am is a senior consultant pulmonologist, and we would really like to have your insights, ma'am, because you practice in a place where I believe the patients are the toughest to convince and manage. So I feel it will be really nice to have your practical insights into how to go about these patients. Ma'am has been very gracious. She was busy with the preparation of our daughter's sports event, but she's still joining us. So, ma'am, thank you very much for joining.
Thank you.
Then we have Dr. Ishani Vaidya, ma'am, from Indore. Welcome, ma'am. Ma'am is a consultant pulmonologist and she's also an academician. She's an associate professor currently. So welcome, Dr. Ishani, to today's CCI webinar. Really looking to have your inputs on how we should manage asthma ahead and what to do in practical problems. So welcome. And then we have Miss Dr. Yash Kedia. कल भाई साहब के नर्सिंग होम का इनॉग्रेशन हुआ है, बट आई रियली वुड लाइक टू thank Dr. Yash for taking out time today. I know it must have been tough, but Yash was one of the first people to say yes with no strings attached. So thank you, Yash. And on behalf of the entire CCI, we wish that the region of Akola is greatly benefited and becomes a true icon as the name is.
Thank you so much, sir. Thank you.
And it would be very wrong of me to not introduce Dr. Stuti Gupta from Delhi. Ma'am is just going to present a very interesting talk on inhalation therapy in asthma, which will be starting. And we definitely give a big thanks to respected Dr. N.H. Krishna sir, the entire webinar team comprising Dr. Atri Gangopadhyay sab, Dr. Narayan Pradeep, Dr. Shivani Swami ma'am, Dr. Ashish Dubey sir, our president from Bhopal, and Dr. Anil Maske from Ambajogai. So I would like to begin our proceedings by Dr. Stuti Gupta's presentation on inhalation therapy in asthma.
Hi, a very good evening to all. I'm Dr. Stuti Gupta. And at the outset, I would like to thank Dr. N.H. Krishna and CCI for giving me this opportunity for presenting my thoughts on this topic. So I'll be just taking a brief info on the inhalational devices in asthma and how small things can go a long way in making a difference in terms of a patient care. So first of all, why do we need this? You need to understand. So error in inhalational techniques are very common. So this is, I'm quoting the systemic literature review and meta-analysis from Henry Crystal. And if you can see the cross-sectional studies and the overall error with different devices with MDI, it is 86.8%. So it almost like only 13% of your patients are taking the treatment properly. It does go down with other devices, but common scenario in India is with the MDI, and you can see how badly we are failing our patients. Another trial that I'd like to quote is from Sanchez J, which is also a systemic review. And even they found a high frequency of poor and suboptimal use, and almost 70% patients were using their inhaler incorrectly. And errors were more frequent with MDIs than DPI. Second point that I like to notice is how we know the inspiratory flow rate, especially in our COPD patients and patients in severe asthma with exacerbation. So, as I'll discuss later, how the peak inspiratory flows are important. Most of the patients at discharge from after an exacerbation of COPD have a peak inspiratory flow rate of less than 60. So if you're discharging them with a DPI, they will never be able to de-agglomerate the drug which is necessary for their treatment. Similarly, again, this is a trial which was published in 2017, and even they found suboptimal inspiratory flow rates, which is needed for the de-agglomeration of drug. And this further led to when we gave them this DIPs, and they further came back with poor drug inhalation and leading to readmissions. So, as you can see from this graph, especially within day 1 to 11 of the exacerbation, if you might see, this is the median PEFR, and you can see it is so below the normal range of the patient. If you are putting a patient on a drug at this moment which requires high peak flow rate or is a high resistance device, they are likely to fail it. So, is it just the exacerbation patients or even our stable patients? So this was a very good study which was published in 2019 in International Journal of COPD, which showed that PFI is reduced even in stable COPD patients in our outpatient settings. And if you go with this peak inspiratory flow and their devices, discordance in the device is seen in 40% of patients. Another study by Pankovic, which was in a Canadian academic center, and they noticed that most of the patients that were being prescribed the DPI, they used an in-check dial device, which I'll be discussing later, and they found that majority of the patients were given a device which they cannot use physiologically. They don't have that, the lung don't have that capacity to generate that much of strength, that much of inhalation to take the drug, which showed which steps of the inhaler had the most difficulty in the maneuver. And if you see, patient have even made mistakes in the steps like removing the cap, shaking the inhaler, holding the inhaler upright. Majority of the problem were in breathing out. They were not able to breathe out completely so as to generate the adequate inspiratory flow, and in continuing to inhale, they take very short breath. Looking at this data, now let's come to type of inhaler devices that we have and how to choose between them and what are the various devices. So, we can basically classify them as 4 types. They are the MDIs, DPIs, nebulizer, propellant-free liquid inhaler. My focus would be more on MDIs and DPIs, but because they form the bulk of our treatment for the asthma patients. So, coming to metered dose inhaler. So, as we all know, a metered dose inhaler has a canister which has an actuator, and when it is closed, you can see the drug cannot escape. After you open it, it can escape. There are multiple steps that can go wrong over here. And as you have seen, to overcome this, a breath actuated PMDI was designed. Okay, the main problem of handheld coordination, that as soon as the patient presses and he has to take a deep breath, which is very difficult in patients elderly with weak hands, poor neuromuscular coordination, this was made to overcome that. And generally, here the actuation is happening when inspiratory flow is approximately 22 to 25 liters. As we'll see, most of your DPIs, which are a medium resistance DPIs, need a flow rate of at least 50 to 90 liters. So taking a breath actuated PMDI is actually much better and much easier for these patients. A very good example of breath actuated PMDI would be a synco breath. This has also been seen in a study by Chapman et al., in which a breath actuated PMDI was successful in 64% of time compared to a 34% time in an MDI, and there was a threefold deposition increase in lung deposition. So this is how synco breath looks like. This is taken up from Cipla website. So they have a synchronized, reproducible, reliable mechanism, and there's a small orifice so that the drug can be dispensed in an aerosol fume and it can be easily taken. So what can you do? What is the other thing that you can offer your patient if he's not able to take MDI on its own? So there comes the role of spacer. So basically what spacer is doing, it is allowing patients some extra time to inhale drug. So it eliminates the need for hand-breath coordination, decreases oropharyngeal impaction, eliminates the cold freon effect, reduces dysphonia. And in patients who have very low tidal volumes or patients with hypersensitive pneumonitis, you may even have to use a valve holding chamber, which helps. So what are the factors affecting the efficiency of spacer? So first of all, the shape. I mean, we have all seen different type of cylinders, different type of pear-shaped spacers, conical spacers, a bulb-shaped spacer. So which is more physiological? The one which is the pear-shaped, because it is effective in reducing particle loss. In the cylindrical one, the particle gets deposited on the wall. Next thing that comes is the size of the spacer. It could be a small, medium, and large. Generally, we prefer a medium size inhaler. Third component is the static versus anti-static. So basically, the static ones are the plastic polycarbonate ones, and they tend to develop an electrostatic charge. And what happens when the inhaler is pressed, this drug goes, and because of the electrostatic charge, it deposits on the wall, which reduces the drug availability. So what is the solution to it? It is the anti-static. So these are the metallic one or the plastic switches which have an anti-static inner lining. So the one with the Cipla, the Virostat ZR, they have an anti-static lining. So what happens? It dissipates the electrostatic discharge and there is less deposition of drug. So as I said, patients who are unable to hold their breath for 4 seconds, they should use a one-way valve holding chamber so that they have enough space and enough time to take that medication in 3 to 4 tidal breaths. And since a valve holding chamber has a reservoir of a drug, they are especially helpful in children. Large volume spacers will contain more aerosols compared to a small volume, but however, they are bulky. Most of the patients don't want to carry them. So, you have to compromise the patient comfort with the drug availability. Okay. And one important point, few of you might have seen that a PMDI in a ventilator circuit is also put. So if it's put in a ventilator circuit, it should be put 15 centimeters from the Y adapter. So this is one study, one very beautiful study by Weilgeber, which shows that, so what they did, they took a spacer and then they washed it with detergent. So after washing that with detergent, what happens that the charger becomes, the spacer becomes non-static. There's a decrease in electrostatic charge. And as you can see, there is significant increase in drug deposition. In the first spacer, there's only 11.5% deposition. In the lower one, there's a 45.6% deposition. So common mistakes with the PMDI, priming, not exhaling up to FRC, not maintaining a tight seal. I mean, I feel in my clinical practice that is the most common mistake. Then with the elderlies, there always a coordination problem with anxious patient. They are always nervous and they are not able to take that deep breath. Then they have to take that slow and a deep inhalation, which you have to teach them. Breath hold, most of us forget, most of our patients forget. So let's go for it. And you might have seen, आप किसी patient को बोलेंगे कि 2 inhaler लेना, and what do you do? So you have to tell them you don't have to do this. It's one actuation. Take the device, take the puff completely, breathe out, keep a 30-second gap and take it again. So this is also one very common mistakes that we do. So, these small mistakes can reduce your drug deposition 26%, 36%, because they increase the probability that your drug is getting sedimented and is developing electrostatic charge. So now coming to the next common device, which is the dry powder inhalers. So as we all know, there are three categories. There are unit dose, there are multiple unit dose DPI, and a multiple dose drug. So unit dose DPI, the most common example is the rotahaler and the nebulizer. You put one single capsule, take it, you remove the capsule cover, throw it, and then when you have to take the next drug, you have to put it again. Second is the multi-discrete. So we have all seen serotype, seroflows. So if you open it, I can see there is this cartridge lid and cap. So here every drug is blister covered, every single dose is blister covered and individually present in the dose. So every time you are actuating, only one blister is opened and the drugs come out. Third option is the multi-dose thing, which is a turbohaler, as we can all see. This is a very special device which has been used in this. The Astranzia claims that they use the inspiratory flow to create a turbulence, and there is a drug chamber in which loose drug is present. So every time that you breathe in, that inspiratory flow gets converted into a turbulent energy which helps to deaggregate the drugs. Okay. So what are the principles of working of a DPI? So during inhalation, the inspiratory flow creates a turbulence and it deagglomerates the drug. Okay. So based on that, there are three categories of drug. There are three categories of particle size forms. So the larger particle size we know get deposited into oropharyngeal and trachea. Below that, by sedimentation into bronchioles, and particles smaller than that go by diffusion and into alveolar sac. So the higher the inspiratory flow, the higher the powder deaggregation, more the fine particle production and lung delivery. See, please, if you have to remember one thing from this whole presentation, just remember this, because the finer a particle, more the drug delivery. So you have to see your patient has adequate inspiratory flow to take the drug. Okay. And that should also be like, so that they just, suddenly takes a puff and they don't take it deep enough and they're just all deposited into the mouth. So you have to see both the sides of it. So based on how much of the inspiratory force is required to break that drug from the excipient, from the carrier, the DPIs are classified as high, medium and low resistance device. So higher the resistance, obviously you need more energy to deaggregate the drug, but that also gives you a finer dispersion, which helps in better deposition. So going by the common devices, the rotahaler is a low resistance device, a nebulizer is a high resistance device, and a turbohaler is a medium resistance device. And most of the devices from other brands are a medium resistance device. So this was about the DPIs, and I really wanted to highlight this point. Another thing is cleaning of device. PMDI should be cleaned with a soft cloth every time after every use. Spacers once a week. Unit dose DPI, you have to deassemble them and you should ideally wash them in a running water for every week. And multi-dose DPI, just clean the mouthpiece with a dry cloth. Just to touch the topic of nebulization, we know the nebulizer, ultrasonic nebulizer, and a vibration nebulizer. However, my concern is how you can increase the drug deposition. So there are spacers for nebulizers as well. This is one of the inline spacer, which I saw recently in a conference by some Shreya's company. I haven't personally used this, but I would really love the feedback if someone has used it. They claim the deposition with this increases by 30%. Another thing is the effect of tight fitting mask. What happens if you have this loose mask which is just falling off the face and it's loose from the tight compared to a well fitted tight mask. So this was a study which was published in Journal of Aerosol Medicine in 2007, and they showed that inhalation through a non-tightly fitted mask led to only 0.3% deposition in the lung. You can see most of it is in the oropharyngeal cavity. However, when you give a properly fitting mask, you can see the difference and you can see how much of the drug is in the lung. There's an enhanced deposition in the lung with 8.2% lung deposition. So, mean percentage increase in FEV1 after bronchodilator treatment. Now, this was a study which was shown whether you should use a face mask or a mouthpiece, and they found that using a mouthpiece led to higher deposition in the lung as compared to the face mask. So, there is a 50% reduction in aerosol delivery to the lungs with nasal inhalation. Most of your patients are trying to breathe through the nose, they don't breathe through the mouth. And biggest advantage of mouthpieces, there is no facial and eye deposition. So this is how a mouthpiece look like. So especially you should use mouthpiece if you're giving nebulized steroid and antibiotics. And please be very careful in your elderly patients with glaucoma. If you're giving them anticholinergics, please give them mouthpiece. So given all this focus that I have said, what matters to you is how do you select the devices of the plethora of devices that is available? How do you select the device which is desirable for your patient? How do you ensure they use it properly and ensure the patient preference? So first of all are the device related factor, which is the ease of use, device efficacy, cost, duration of use. Then disease related, especially very important COPD patients, which is the severity of disease, respiratory status. Then drug related. Like as I said, it's better that you give antibiotic with a mouthpiece. Type of drug, combination, frequency, strength, and patient related. Dementia patient, elderly, you can't expect a hand-eye coordination from a dementia patient. If a patient has a lot of deformities, like your patients with RA, they won't be able to grip the inhaler well. So you have to see all these points. So this is a very good flow chart from Egan's, and they said, how do you go about it? So basically, first of all, you ask your patient with a placebo and ask them to take the MDI. You see the inspiratory flow, and you can check it you can see it in the PFT report as well. If you think the patient is able to mimic the steps properly, you can go with the MDI. Otherwise, if you feel the patient doesn't have that much high inspiratory flow, you can choose a breath actuated MDI, or you can give them a spacer, which is a better option and a much cheaper option. If your patient has a good inspiratory flow, you can go for a DPI as well. If none of these are happen, preferably go for a nebulization. Okay. Similarly, if your patient has acute symptoms or very severe airflow obstruction and is unable to take deep and rapid inspiration, please go with an MDI and a spacer or go for a nebulizer. Another thing, if you can coordinate, then you took a PMDI. If you cannot coordinate, go for a DPI. So this was a paper by ERS, which was published in 2016, and they divided the dose. Whether the patient, first of all, you see whether they has a good actuation in inhaler coordination. You ask them. So as soon as they press, they have to take a deep breath. If they are not able to make that coordination, they become a poor actuation inhaler group. So you shift to the right side. So next step is seeing the inspiratory flow. How can you see that inspiratory flow? You can either see the PFT report, and outside countries there's a device called InCheck Flow, in which I will discuss. So if your inspiratory flow is more than 30, you go for PMDI, BAMDI, or a DPI. But if your inspiratory flow is less than 30, please take only meter dose inhaler. And obviously nebulizer can be given for all of them. So these are the steps. I'll leave the slide on for 10 seconds. You can read to confirm that all the steps are being followed by your patient. These are the important steps that you need to remember. So this is one other device that is available in UK and US. Cipla is also working on it to bring a device like that. So this device has multiple different type of inhalers drawn onto it, and you can put in the resistance and ask the patient to breathe through the disposable valve and see which one they are. And remember, when your patient cannot go for, it doesn't have good inhalation coordination, doesn't have good inspiratory flow, better give them nebulizer. Thank you.
Wow. Well, thank you, Dr. Stuti. That was really an in-depth analysis of how we actually deliver our drug and what is one of the most unique and important parts of asthma management. So definitely even GINA 2026 also gives some, or I would say a lot of importance to that particular inhaler shaking thing, immediately shake and use. And there is a lot of stress given in this upgrade also. And you covered a lot of details, and I'm really thankful because you even gave a few updated points for all of us to ponder upon. So I would again now like to invite all of my panel, which is really, I know, very much inspired to commence this discussion. And I would like to begin with Dr. Rubeena Rathi, ma'am. And ma'am, I would just like to ask you one thing. Let's keep things very simple. What is asthma? Please tell us.
It's a very thank you, Dr. Ravi, and everybody in CCI for giving the opportunity. And it's a very basic question, and I think everybody knows. But just to recap with our knowledge, it is a simple. It's a chronic inflammatory process that is being characterized by wheeze, shortness of breath, chest tightness, and cough. And there is airflow limitation may later come may persist in this, and there will be a variable expiratory flow also. So with all this hyper in short we can say that the hyper responsiveness of the airway is what we tell asthma is on.
Right, right. So means it's you might be wondering why I started with such a basic question, but the basic thing is, that is where it all begins with our own thought process and understanding of asthma. The basic variability always remains, howsoever many guidelines and updates have come, but the variable nature of asthma is something which makes it very, very unique. So, Dr. Ishani, again, you might be angry on me for asking you a basic question, but tell me, how is asthma diagnosed?
So, sir, good evening, everyone. Basically, asthma is a clinical diagnosis. It is characteristic symptoms of asthma being chest tightness, wheezing, episodic cough, and breathlessness. And these symptoms are variable in time and intensity. This is the characteristic feature of the symptomatology. And to diagnose asthma, we also need to prove or document the variability in uh, lung function. Basically, with spirometry, we can document the post bronchodilator reversibility of 12% or 200 ml. And if spirometry is not available, then we can measure peak expiratory flow. And if it is more than the improvement is more than 20%, then it favors the diagnosis of asthma.
Right, very well put. But I believe that GINA 2026 also touches on this. I think the bronchodilator variability of 12%, I feel they have gone down to 10% also. If I believe I'm correct, I'll be discussing this more in subsequent discussion. So, Dr. Nishtha, one very important thing is, as and as we see more of asthma, there are very many clinical phenotypes of asthma. So would you like to comment on what these clinical phenotypes are actually?
Yes, sure. So earlier, asthma was known to be called as like a single disease, like all other diseases that we know about. But now, over many decades, it has been come to know that asthma is a multifaceted disease. Many phenotypes are there, starting from our old age, old friend, that is the allergic asthma. Allergic asthma is a type of phenotype which we have always known as asthma. This a patient with allergic asthma has eczema. They might be suffering from allergic rhinitis. They have high eosinophil counts. They have typical childhood onset of asthma, and this is the typical patient who responds very well with inhaled corticosteroids. So this is the most common phenotype which we have been seeing from always. So now the second type is the non-allergic asthma, which all of pulmonologists we fear because this is due to the fact that this phenotype is not responding well to the inhaled corticosteroids. As well as these patients have neutrophilic type of category of inflammation, as well as this is the category of patients we were searching for while we were planning to do thermoplasty when it was there in the guidelines earlier. Then another category of phenotype is the late onset. Late onset asthma is generally seen in the females. Many times it is associated with the various occupations. And this is also a type of phenotype that does not respond very well to inhaled corticosteroids. And then we have got another phenotype that is obesity associated. Obesity associated phenotype is also not very well responsive to inhaled corticosteroids, as well as it responds very well to decrease in the body weight of the patient. And then we also have another phenotype that is irreversible, that is not showing good bronchodilator reversibility, as is the defining characteristic of asthma. This happens in the patients who have been having asthma for like many years. So, due to which the airways become non-responsive, and due to which the response to inhaled corticosteroids also decreases. So these are the non-responder, and many times we come to label them as severe asthmatics. Then the last phenotype that I can remember now is that of the cough variant asthma. So many times we see patients in our OPD where the patient complains that he does not have any breathlessness, but he has cough. And when we go ahead with the bronchial responsiveness and we check either with going ahead with the bronchial provocation test, that comes to be positive. So that is a cough variant asthma, and that also responds very well with inhaled corticosteroids.
Right,
So I
right.
believe that there is a big array of basket of phenotypes that we have now of asthma.
Definitely. It simply means that, if in a given OPD, you're seeing more than 10 types of asthma patients, all 10 might be different from each other with simple clinical features differentiating them. And the response to treatment being one very important criteria for diagnosing them differently. So very well explained, Dr. Nishtha, truly spoken like a person who has seen thousands of asthma cases up till now. Now, Dr. CVK, sir. All said and done, sir, what are the criteria for initial diagnosis of asthma in adults more than 18 and in children 6 to 7? And I am asking historically, history में कैसे पकड़े उनको?
Yeah, Ravi bhai, first of all, wonderful moderation from your end. And then thank you for making you partner in the crime last minute. See, it's a absolutely honor to get participated in a CCI World Asthma webinar, and which we are doing for the past 6 years relentlessly.
Yes.
So I was in fact missing, and then in the last moment you agreed to make me part of it. But coming to the question, initial diagnosis of asthma. In Indian scenario, Ravi bhai, what is main thing which I believe is the biggest mistake? Patient coming to cough, patient coming to probably recurrent wheezing, particularly in children, will be labeled as a asthma. Yeah. And then chronic coughs will be treated as a asthma. We call probably cough variant asthma or something like that. This is the biggest mistake that we are doing. But what to do systematically to ensure we will identify and treat our patients in a very systematic manner, so that the diagnosis of asthma is both included and excluded in respective patients. And as Dr. Nishtha very clearly mentioned, so many variants of asthma, so many phenotypes. It is very, very important. Being a pulmonologist, we have to start phenotyping asthma from the very beginning. If not, at least the moment when we are finding the difficult to treat asthmas and severe asthmas, as per GINA 2026, very clearly mentions the moment you are contemplating severe asthma, you must phenotype the patients. So coming to the question per se, yes, the variable nature, it has been explained by Rubeena ma'am. And then what is the spirometry confirmation? Dr. Ishani has spoke very well. And then here, I'm just reiterating, it's very, very important. Episodic wheeze, episodic cough, breathlessness with nocturnal symptoms, seasonal variation, triggers for exposure, particularly cold weather or some amount of, foods or pollen exposure. And there's a classical family history. Okay, if these all included, it is not a challenge. But again, if you see chronologically, over the past probably, since 1993, the GINA exists. So since then, probably early 2005, when we were postgraduates, so the emphasis was more on symptomatic identification of asthma. So during that course, what has happened is there is a whole lot of overdiagnosis has happened. Empirical usage of both SABA and ICS was used. But eventually, what was the result? GINA has identified, research has identified very clearly. We were, well, with that symptom-based approach, we were diagnosing more of asthma to or adding tag asthma to diseases like anxiety, obesity, GERD, post-viral cough, COPD sometimes, or they are all mislabeled as an asthma. And in this era, with so much of objective proofs available, we must ensure that the reversibility of FE1 and then PF for reversibility should be documented along with the classical history and then radiological also. If someone is having recurrent exacerbations, but it is very, very important, please ensure both in children and then adults, our diagnosis is correct. I just want to bring into notice, having practicing at a tertiary care center, what happens is, once in a while, we do see patients who are labeled as an asthma may be harboring a carcinoid tumor or a foreign body as well. So when someone is having recurrent exacerbation, it is very, very important to ensure that our diagnosis, whether correct or not, based on the objective evidence. And that's all from my end. And children, they no longer, they don't behave highly different from adults. But again, the challenges in children are, we cannot document FE1 reversibility, particularly if they are less than 5 or 6 years old. GINA 26 stresses that probably PFT is FE1 has to be documented in children more than age 5 years. And nocturnal symptoms are more often in patients with pediatric age group. And that's all from my end, Ravi Bhai.
Sir, thank you. Thank you for that very, very comprehensive answer. Because really, sir, I do agree with you. Historically, how the number of words in your answer itself tells that the history is so important in the differential diagnosis, the mislabeling of asthma, particularly in pediatrics. A lot of Waldry is often diagnosed and labeled as asthma, and then the child carries that tag throughout his teenage also, and it becomes a big burden for the parents too. So in order to confirm that diagnosis after the history, Dr. Yash, I would like to bring you in the discussion that this variable expiratory flow limitation. Can you tell us how to confirm this, what it is, how it helps us?
Yes, thank you for the question, sir. So, like Dr. CVK sir had already mentioned, that most important thing is the history. So we need variable symptoms as well as confirmation of variable expiratory flow. So what does this variable expiratory flow means? It means that the patient's expiratory flow is different at different instances. There may be diurnal variation, there may be variation associated with the use of certain inhalers, or there may be difference in the expiratory flow between two visit to the doctor. So the most common criteria that is typically recommended is the use of either FEV1 or FVC. Either of the two can be used. And we need to document a change in FEV1 or FVC, or that is an increase in FEV1 or FVC by more than or equal to 12% and more than or equal to 200 ml. So both the things are important, not just the percentage predicted value, but the percentage predicted as well as the absolute value. Both are really important over here. And the diagnostic confidence increases if the increase is by more than or equal to 15% and more than equal to 400 ml. If FEV1 or FVC is not available, increase in peak expiratory flow by more than 20% can also be used as one of the diagnostic criteria. This is done after 10 to 15 minutes of giving either salbutamol, or now GINA even recommends the use of ICS LABA containing formoterol for testing bronchodilator reversibility. ATS-ERS in 2022 recommended that more than or equal to 10% can also be considered. However, the GINA 2026 still very specifically says that more than or equal to 12% and 200 ml is still the criteria that is to be used while diagnosing variable expiratory flow rate. This is one of the methods to calculate variable expiratory flow rate. Other thing is, after 4 weeks of use of an ICS plus LABA containing therapy, the PFT can be spirometry can be repeated, and the FEV1 and FVC or FVC value can be re-examined to see if there is a difference of more than 12% and 200 ml, or in between two visit to the doctor. Apart from this, in the patient, if your setup does not have a spirometer, so a normal peak expiratory flow using a peak flow meter, the patient can check the peak expiratory flow at home and can report to us by maintaining a diary of his peak expiratory flow in the morning and in the evening to calculate the daily diurnal variability, which should be more than 10% in case of adults or more than 13% in case of children. Now, how do you calculate this daily diurnal variability? It is the difference of the highest value of peak expiratory flow minus the lowest value of peak expiratory flow, that is divided by the mean value of the peak expiratory flow. It is the mean value and not the highest or the lowest value. That is something that is to be remembered while calculating the daily diurnal variability. Apart from this, bronchoprovocation test can also be used using either methacholine or hypertonic saline or exercise challenge. So each has its own criteria. When using methacholine, a decrease in FEV1 of more than 20% is considered to be diagnostic of variable expiratory airflow. Or when using hypertonic saline, a decrease in FEV1 of more than 15% is taken into consideration. Or while using exercise challenge, a decrease in FEV1 of more than 10% and 200 ml is taken to be diagnostic.
Beautiful, comprehensively answered, Yash. And I'm sure that if you really follow these, you can actually have the correct cases of asthma being diagnosed. And
Yes.
I really hope that in your upcoming setup also, you'll soon be offering things like bronchial provocation testing in some time also, apart from your spirometry. Because see, ultimately, those complicated cases, somebody has to answer them. And
Yes.
for that, I think you'll be needing all of these modalities.
Yes.
So very beautifully answered. And Dr. CVK and Dr. Yash have really outlined objectively how to go about it. But Dr. Stuti, आप you gave the photograph of that particular peak flow meter which was available in US and UK. I think that was what Dr. Yash was hinting towards also, which can be useful in diagnosis apart from spirometry. Tell me, Dr. Stuti, what are the patterns of respiratory symptoms that are characteristic of asthma? Just both or whatever they say, try to give it to a summary to me.
So, basic classic symptoms are the wheeze, shortness of breath, cough, and chest tightness. And the most characteristic thing is wheeze, अगर मैं सीढ़ी भी चढ़ जाता हूँ तो भी सांस नहीं फूलता, और कभी कभी कमरा साफ करने के बाद बैठे बैठे भी सांस फूल जाता है. Then the symptoms are often worse at night or in early morning. They may be triggered by viral infections, exercise, allergens, changes in weather, and laughter. And one very characteristic of asthma is symptoms that develop after exercise, which is not because of bronchoconstriction. So if your patient is saying that he starts exercising and after 5-10 minutes he's getting breathlessness, or the breathlessness after a short exercise if it's happening, then also it is characteristic of asthma.
Right. Well, so that means what you are basically stressing on is symptoms which are like wheezing, which come after exposure to particularly inciting agents. That is one very important symptom pattern of asthma. I do agree with you. Dr. Rubeena ma'am, just tell me, with so many commonly presenting symptoms, particularly let's say in the younger age group, let's say 6 to 11 years child, very frequently we even as adult pulmonologists have a lot of children pediatric asthmatic cases or pediatric cases coming to us. So in 6 to 11 years, or let's say teenagers, 12 to your early adulthood cases, what are the common differential diagnosis we should keep in our mind?
Actually, in with the change in environment, what with the air pollution and everything, now children are facing a lot of problems, and day to day, almost daily, get to see 5 to 6 kids with all these problems. They are coming, they are not able to play. Frequently, parents will say कि ये बच्चा हमारा खेल नहीं पाता, थोड़ा सा भी चले तो बहुत सांस फूलता है उसका, and we don't know what is this going on with the child. ऐसे पहले कभी नहीं होता था, and suddenly now it is happening with the child. So we usually say कि हो सकता है कि भाई they are not ready. Actually, what I see in my practice is कि parents are not ready to accept that कि their child is having asthma or asthma like symptoms or allergic conditions. So what we see with the differential diagnosis is general symptoms तो हमको मिलेंगे, like everybody told us अभी, sneezing हुआ, sneezing, chest tightness, wheeze and cough. This we will be getting it, and with different symptoms, like if there is a detailed table in the GINA 2026 that is there with the differential diagnosis, which says that if there is sudden onset and there is unilateral wheeze, then it could be a foreign body inhalation that we should keep in mind. And if there is recurrent chest infections and productive cough, then bronchiectasis could one of the reasons, and inborn errors of immunity also. And most importantly, in preterm delivery, that we should ask that the child is born on term or it's a preterm baby. So that could be bronchopulmonary dysplasia. And if there is excessive cough and mucus production or GI symptoms are there, then cystic fibrosis is also one of the differentials that we should keep in mind. And uh, we all know that every dyspnea is not related to lungs only. The cardiac part we should never forget and never leave the heart behind, because when lung is uh, breathing, the heart is beating. So the beating heart has to be taken in mind, and if there are cardiac murmurs, one has to auscultate. If cardiac murmurs are there, then the congenital heart disease is also to be considered.
Right, very beautifully answered, ma'am. And really, in children, at times, you actually become confused. You, at the back of the mind, you always have the foreign body, foreign body, foreign body going on, going on. So, and cardiac is one thing which definitely becomes a challenge, because, in our setup, you send the patient for an echo also, no? Then also the cardiologist says, मैं pediatric echo नहीं करता. Then you are caught कि यार अब how to rule it out, not looking like asthma. But I agree with you. This is something which is very important. Now, Dr. Ishani, tell me, lot of adults come to us. Now, what is that differential diagnosis which we should be aware of at all ages, not only pediatrics, but even in elderly?
Okay. So particularly if we are considering adult people, let us first focus on symptoms. If the patient is presenting with cough and breathlessness, wheezing, then most common differential diagnosis which I come across in my practice is post-infective bronchitis. The patient presents with a protracted course of cough and wheezing and dyspnea. Then with smoking and environmental exposure of pollutants so common. COPD is also a very common diagnosis, and we need to be very careful to differentiate between the two, as ICS are the mainstay of treatment in asthma, and ICS need to be preferably be avoided in case of COPD because of the risk of pneumonia. Um, Also, GERD is a very common cause of chronic cough, which needs to be addressed. In adults, cardiac condition needs to be ruled out, as particularly the symptoms are similar. Both the asthma and cardiac conditions both present with nocturnal symptoms and exhaustional symptoms. So we need to differentiate between the two. Then ILD is a common diagnosis in our respiratory OPD. Um, ILD needs to be ruled out if there is a repeated history of repeated infections and cough and sputum production. Bronchiectasis is a diagnosis which we need to consider. If there is a prolonged wheezing which is not responding to bronchodilators, particularly in smokers, then in such cases we need to evaluate and look for any central tumor which is causing the bronchi.
Practically, I think, Ishani, the whole pulmonology textbook and all the chapters can actually be enumerated over here. But I do agree with you with so many confounding factors in adults like smoking history, pollution exposure, occupation exposure. Yeah, I think primarily COPD followed by some other intrabronchial causes are some very important points which we need to look into. That is why I would like to ask Dr. Nishtha a question. Tell me, if it's so simple, if it's so universal, then why is it important to confirm the diagnosis of asthma? उससे फायदा क्या है?
So earlier it was thought that it is a disease of childhood, and when the disease progresses into adulthood, it slowly diminishes and the symptoms also decrease. But now the data that has come out, they are a big eye opener. What the latest data is showing is that around 18% of global asthmatics are Indians, and the shocking thing is that 43% of global deaths that are happening due to asthma are happening in Indians. So that means every second global asthmatic, the person who is dying, is an Indian. So every second asthmatic. So that is such a shocking data that has come out. This data in turn emphasizes that we need to emphasize on asthma. We need to look and search for asthma. What are we missing? Why are the deaths happening? So if we retrospectively think, why is the mortality happening? So the reasons on thinking, they come up to be like many, or probably one of the main reasons is the underdiagnosis, that we are not diagnosing properly, or the patients whom we are diagnosing are not being treated well, or there are lots of barriers to treatments that we are facing. For example, the stigmas that are still very much prevalent in the society against inhalers. So if we look at the GAN data, the study that we conducted between 2015 to 2020 in the school children and their respective parents, that data came out and it showed that around amongst the 4 children, asthmatic children, only 1 is getting diagnosed. 3 out of the 4 wheezers, they remain undiagnosed. And the 1 child that is being diagnosed also is not treated well. The stigma, the barriers are very much, and in fact, in the study, GAN study also, it was found out that amongst the 4 children that were diagnosed, only 1 was being treated by inhaled corticosteroids. So the profound data, these numbers, they are shocking. And these numbers in turn force us to look back and again question whether we are treating asthma correctly, whether we are diagnosing asthma correctly. Despite this age-old disease, still we are puzzled by why we are not able to treat the disease, as well as why we are not able to decrease the death related to this disease.
Right. Matlab, really, yeah, this grand survey data which you have presented, and it's so huge because so much mortality, childhood mortality, so much of our Indian asthmatics being underdiagnosed and being so high on the mortality list is really alarming and surprising. So we need to really concentrate more on our academic efforts. We need to really propagate the message of correctly diagnosing asthma much more strongly than it is actually being done. And I feel if any pediatric patients come across that fear that people have of being labeled as asthmatics is something which needs to be really addressed. It's very important because, like Dr. Nishtha told, these data don't give a very good picture of what asthma control is there in our country. We need to do more. So, Dr. Yash, you very beautifully elaborated. Very, yes, sir, please, sir.
Yeah, a quick comment. I was just getting the one of the best analogy here to state, Ravi Bhai. See, if we are not doing well, or if students are not doing well, imagine at academics. Okay, what they comment? They, who is your teacher? Who is your parents? So the whole responsibility is on thousands and thousands of chest physicians who are there in the country from Srinagar to down south Tamil Nadu. So it is very, very important. We should all take this into our shoulders and ensure that we break the myths in the public and also in our colleagues, particularly physicians and then family physicians kind of thing, whom we cannot treat all the 4 to 4.5 crore population in Indians. Okay, we cannot manage chest physicians, pulmonologists alone. It is our responsibility to disseminate the knowledge so that the correct practices goes into the public and also the physician fraternity.
Yes, sir. Point very well taken because that is why our role as pulmonologists in asthma becomes so important because I have several times seen in non-pulmonology OPD, अरे asthma ही तो है, अरे inhaler ही तो देना है. Matlab, they take it so lightly, it seems a joke at times when we give so much importance to asthma. So I think we need to concentrate more, we need to motivate more. Now, coming back to our discussion, Dr. Yash, you very beautifully enumerated a lot of detailed tests that we can see to confirm variable expiratory airflow. So anything else you would like to add other than spirometry that we can use to do and diagnose asthma?
So currently what Gina says is the only way to confirm that the patient has asthma is variable symptoms and variable expiratory flow. So that is done by spirometry. Apart from normal spirometry and bronchodilator reversibility, the other test that I had mentioned was bronchoprovocation test, which can be used to see if there is reduction in FEV1 after giving a provocative agent such as methacholine or hypertonic saline. Apart from that, there are certain surrogates which can be used to indicate that the patient might have asthma, but these are never diagnostic of asthma. These can be the common type 2 inflammatory markers such as absolute eosinophil count or IgE levels, which are commonly elevated in asthma, but definitely not in all kinds of types of asthma or all phenotypes of asthma. As Dr. Nishtha had previously mentioned, that there are certain obesity associated phenotypes or certain neutrophilic phenotypes where we will not see elevated eosinophil count or IgE levels. Apart from that, FeNO, that is fractional exhalation of nitric oxide, can again be used as surrogate, which will show a FeNO level of more than 50 parts per billion for in adults and 35 parts per billion in pediatric population, again suggesting that the patient might have asthma but not diagnostic. And at the same time, low levels definitely do not rule out asthma because FeNO has high variability based on different factors, not certain factors such as age and sex itself, as well as smoking or the use of inhaled corticosteroid also affect the level of FeNO. So it is not diagnostic, but it can definitely indicate towards asthma. Allergy testing using skin prick test and specific IgE levels can be used to show atopy. Again, atopy, as we know, is a common feature of asthma. So again, can be used to show that the patient might have asthma. Imaging such as CT thorax can show hyperinflation, mucus plugging, again suggestive of asthma, but again not diagnostic. And sputum eosinophil levels also. So basically, all type 2 inflammatory markers again can be used to as a surrogate to show that the patient might be a case of asthma, specifically eosinophilic variant of asthma.
Right, but I fully agree with you. Some when spirometry is not feasible or the patient is not able to do, we do take care of these tests to give a pointer towards asthma. But again, spirometry is spirometry. I would just like a small question to Dr. Nishtha. Ma'am, आज तक ब्रोंको प्रोवोकेशन टेस्ट से आपने कितने अस्थमेटिक डायग्नोस किए?
So histamine challenge test we were doing earlier, but now we have discontinued. So earlier, yes, we were doing so, but it is a little bit risky.
मानिए मैडम, अगर अस्थमा भवन वाले बोल रहे रिस्की है, तो मैंने तो अपने जीवन में कभी नहीं कराया, न कभी उससे डायग्नोस किया, बट ठीक है, यश भाई के नर्सिंग होम में हम भेजेंगे एक दिन. तो सीवीके सर आप तो बैठे हैं बिल्कुल जुबली हिल्स अपोलो में, मुझे बताओ ब्रोंको प्रोवोकेशन टेस्ट कितनों में करवाया सर अभी तक?
I have read a lot.
So the Yash bhai, I'm giving you a great business idea. Buy it, do it, and propagate it. You will get a lot of patients coming to Akola.
As long as you are ready to manage the emergency with me, sir.
Yash will have now then sleepless nights.
Right.
That's what. As long as Ravi sir is there to manage the emergencies, I don't mind.
So it means definitely guidelines give us a lot of thought. Well, food for thought, but practically, I think spirometry and having a trained spirometry technician is something which is like a boon, and we should really try to concentrate on that quite a lot. So
one thing that I forgot to mention was FOT and iOS. So FOT and iOS again are coming forward with huge vigor and everything. So FOT and iOS can also be used to show obstruction as well as bronchodilator reversibility. The only issue is we do not have very specific cutoff values as of now. Each person and each machine has its own different set of criteria that it uses to use as a cutoff for obstruction. So we don't, unlike spirometry, we do not have very specific values, and still that should be taken with a pinch of salt.
Yash, good thing you brought in FOT and iOS. Whenever at CCI we are conditioned, जब भी FOT iOS का नाम आता है तो डॉक्टर अत्री का नाम लेना कंपलसरी होता है. First guy in East India, first guy in North India to acquire FOT iOS. So Dr. Atri, a big hello to you. And Dr. Yash has mentioned FOT iOS. Definitely one of the most best things that are available and making diagnosis so easy in those patients who find it difficult to do spirometry. Now, Dr. CVK sir, suppose a patient comes to us already who has been prescribed ICS by someone outside, but we need to confirm asthma in him. So what should we do in that patient, sir?
Yeah, this is a most practically important question, Ravi bhai. So in our practice, particularly when we are sitting at a tertiary care center, so it is not uncommon to see patients coming on a lot of inhalers. Okay. And once they are on inhalers, any inhaler for that matter, if they have some inhaled corticosteroids, the moment then diagnosis become a very, very challenge. And that the reason for this is the airway inflammation which was there subsides, the bronchodilator reversibility which was there is no longer there. And then when you test spirometry and then pheno, eventually the pheno would have been normalized and the spirometry would have become normal. So it is always important, those who are listening, I was told by our Krishnana that there are roughly around 2,200 logins.
Wow.
So today, so we are extremely happy. And then please, those whoever are listening, so please confirm the diagnosis. Take that extra step to confirm the diagnosis before starting the patient on inhaler. And then even if they are on inhaled corticosteroids, it is our as an expert's responsibility, take the proper history, and whenever the patient is there, and then if the patient is not getting better, then only he is reaching you. And give that extra 2 minutes time and check the inhaler adherence and then technique of the patient. And if there is patient is showing normal spirometry, then probably we all discussed so far that it's a variable obstruction. The probably morning there is a different FE1 will be there, morning levels. Okay, there will be PFR will be variable when compared to evening or afternoon levels. So please stop the inhaler cautiously whenever there is no, significant compromise in FE1, and then recheck with bronchodilator testing. And more importantly, if the patient is from remote, give them a PFR, okay, peak expiratory flow meter, and then ask them to assess their chart it for 2 weeks or 3 weeks, and then come back again, so that we'll have the variability of PFR. And then particularly in adults, it is 10% variable. It's an indicator of, hyperreactive airway disease. And then if it is 13% in children, we can confirm that this is a hyperreactive airway disease. And as discussed rightly by you in the earlier discussion, so bronchial provocation testing, it is highly impractical. I don't suggest. So despite on ICS, it is very, very important. Patient can be, if we check the eosinophil levels and IG levels, that may become clue to you. And if everything is normal and patient is receiving ICS, and if it is not fitting to the criteria of asthma, then it is wise to say that it is the time to diagnose a alternate disease rather than a asthma. Over to Ravi bhai.
Yes, sir, very correctly told, sir. And definitely, we need to be more careful in such a situation when it might be masked by the use of ICS. But it is important to still subject him to the tests, and history is paramount in such cases. Dr. Ishani, I would like to ask you that situation in which you have an asthmatic who might be elderly but might also be a smoker. So, how would you go about managing or diagnosing such cases?
So diagnosing asthma in elderly is tricky. It is many a times underdiagnosed because of poor perception of symptoms like dyspnea, because of reduced physical activity. So they don't, elderly people don't report their symptoms early during the disease course. The two common differentials which we need to consider in case of elderly as well as smokers or ex-smokers are first is cardiac disease and second COPD. These conditions, we need to diagnose asthma apart from these conditions, as in whether we need to confirm our diagnosis of asthma, as many a times these conditions can even overlap or coexist, and we need to treat them independently. So subjecting a patient to an elderly patient to cardiac workup with modalities like ECG, echo, pro-BNP levels, of course, PFT and chest X-ray to rule out alternative diagnosis like bronchiectasis or malignancy is important. Then, in case of COPD, in case of smokers and ex-smokers, diagnosing COPD is very important, whether it is asthma or COPD. So we need to consider the symptom pattern. If the symptoms are variable in time or intensity, it will go more in favor of asthma. If the lung functions show a marked bronchodilator response, COPD or overlap can be ruled out. If the onset of symptoms is before the age of 40 years, asthma is more likely. If it is associated with triggers, asthma is more likely. If the symptoms are persistent and if there is poor response to inhalers, then COPD is more likely. So we need to evaluate the patient comprehensively.
Quite it. I fully agree with you. And I feel, at that times in elderly asthmatics, getting a CT scan at times becomes very useful. It helps us clarify things quite a lot. So I fully agree with what you have told, and really thank you for that comprehensive answer. In eastern parts of Delhi nowadays, whenever somebody coughs or becomes breathless, they turn to only one person, and that is Dr. Stuti Gupta. So, Dr. Stuti Gupta, please tell us, a patient presenting with persistent cough as the only symptom, इसको भी अस्थमा हो सकता है?
Yes, definitely, sir. And we are getting a lot of cases like this, especially with the pollution setting in Delhi. So, I mean, specifically patients, any patient who is coming with cough, which is worse at night, which is worse with exercise, and very specifically at times when patient is crying or laughing, when the patient is coughing, that can be really associated with uh, asthma. That would be a cough variant or a cough predominant asthma. I mean, there are multiple differential diagnoses. You have to rule out upper airway cough syndrome, GERD, chronic sinusitis, post-nasal drip. But yes, and obviously drugs like Telma, which most of our patients are, majority of patients are. But any of these, then it could be asthma. The weird thing is, in such cases, the spirometry would be normal, and you will have to demonstrate a airway hyperresponsiveness or a by a bronchial provocation test, which again is a little difficult. So most of these cases come to clinical judgment also.
हाँ मतलब
When you follow them up longitudinally, they may develop wheeze and significant bronchodilation later on. One more thing that we can do is we can check for sputum eosinophils, although it's not very much done. But I think at times if your patient is not getting response to anything and there's a lot of diagnostic dilemma, sputum eosinophils and or pheno levels can be checked.
एग्रीड मैम, इसीलिए अपनी क्लिनिक पे इन सब चीजों की तैयारी रखना, इट्स वेरी इंपॉर्टेंट, बिकॉज आई थिंक ऑल ऑफ अस सिटिंग ओवर हियर, यू कैन हैव वन पेशेंट कमिंग कफिंग एंड शोइंग ऑल ऑफ अस, and still he might not be satisfied and go to guys to keep on checking. So this persistent cough asthma, like Dr. Nishtha also told and Dr. Stuti also told, is one thing which India level pe this is a challenge, and we need to take it up, and we need to diagnose asthma in such cases on a clinical history. Now Dr. Rubeena, हमारे यहाँ पे कुछ पेशेंट आते हैं जो आते से ही बोलते हैं कि सर मुझे तो इयोसिनोफिलिया है। तो मैडम ये इयोसिनोफिलिया की क्या माया है, प्लीज थोड़ा सा इस पर रोशनी डालिए।
To be on the lighter side, eosinophilia is one of the biomarkers for asthma, right? And it varies from the ranges are different for different labs, and for national and regional labs, they have their different ranges. But exactly, if we say that eosinophilia is always present in asthmatic, it is very unlikely to say that, because in sometimes we don't see eosinophilia in asthmatics. Clearly, we find that the patient is asthmatic, but the eosinophil count is absolutely normal. So we see blood eosinophil. We check for blood eosinophil count. They in the guidelines they have said sputum eosinophil also. I have not done it yet, and I have not checked it yet. The sputum eosinophil counts, but definitely we go for blood eosinophil counts. But they vary with different ethnicity of a person. It varies with the gender of the person, with the when the sample is taken, like early morning samples, the eosinophil counts are more rather than taking the sample in the afternoons. Then the smoking history of a patient, and in the parasitic infection also the eosinophil count tend to rise, and in allergic conditions also it increases. But usually when we are sitting in the OPD, the patient comes last to us. After moving to all the GPs and everybody, the patient comes last to us taking all steroids, all sorts of inhalers, the Eracort, the Buticort, and everything they have tried and tested. So when we go for the eosinophil count in that patient, we usually see there is a decrease in the eosinophil counts. So eosinophilia is one of the markers, but not a definitive markers of asthma. And definitely, I would like other people, other dignitaries here, if they could highlight on saliva eosinophilia, because I have not tested yet and I have not experienced it.
I also can't say that I have. Yash, you come from All India Institute very recently. वहां पे बता दो भाई कुछ experience हो यार ये salivary.
Even we have never used, sir.
CVK sir,
Sputum eosinophilia, we were doing it. So more than 3% is the cutoff. So the procedure for doing sputum eosinophilia is a complicated procedure. The reagents that are used, they are also like not very much freely available, but we have been doing it. Our staff is also trained with this, and we do it in suspected patients of asthma that are not exactly their reports are not aligning well with the diagnosis of asthma. Then we go ahead with this sputum eosinophils.
Okay, so means
One
as a
important thing, Ravi Bhai, I want to bring it here. See, GINA 26 very clearly mentioned, unless you are finding a patient who is non-responder, so there is no significant role of, identifying if it is, no. For example, the patient with a plain ICS, if he is maintaining very normal lung function, what is the point of, looking for eosinophilia and all those things? But the moment he becomes a difficult to treat asthma, or more particularly, GINA 22 is clearly mentioned, if it is a severe asthma, it is very, very important to phenotype this patient. Until that point, in clinical practice, I'm not bothered about whether my patient is having a AEC of probably around 200, 300, 400, 500. But I would be rather, more importantly, if my AEC is more than 1000, okay, then eosinophilic lung disorders and all other, tropical pulmonary eosinophilia, all these things have to be brought into the differentials and then identify appropriately and manage it.
It's very, very important. So definitely eosinophilia is one such thing which should make us think quite a lot. And if anything apart from asthma, it should really raise a suspicion in our mind. Very, very important point. Very nicely answered, Dr. Ruby ma'am. Now, Dr. Nishtha, one thing which really is very important, which we all pulmonologists need to handle with a lot of tender care, is when pregnant females come with asthma. So, would you like to give us any pointers as to how to manage or diagnose such cases?
So, pregnancy is one ambiguous situation where the asthma can take all the three ways. It can remain as it was before, it can increase, or it can decrease. One third of pregnant females, they go into exacerbation. So many a times what happens, the clinicians are really reluctant in giving them inhaled corticosteroids, just just looking at the teratogenic effect and of the medicines. But I want to make a point clear here that it is very important to treat the asthma, uncontrolled asthma of a pregnant female. That is much more important than uh, um, uh, not giving the medicine to the patient. So, and it has been seen, the patients, the pregnant females who had asthma and which was left uncontrolled, they had higher chances of preterm labor, they had higher chances of preeclampsia, they had higher chances of perinatal mortality. So it is very important that the asthma, if it increases during pregnancy of a asthmatic female, then it needs to be treated appropriately with the use of inhaled corticosteroids. And if and it has been shown that if the inhaled corticosteroids are given in an asthmatic female between 12 week to 20th week, it has been shown that it decreases the chances of the child being born with asthma. And cetirizine and other medicines can also be given to the patient in line with as per the symptomatology of the patient is one. And second, did you ask regarding obesity also?
Yes, definitely. You had mentioned something when you had answered phenotypes. Would you also like to comment on obese asthmatics? Anything special to do in those?
So the data shows that around 30% of obese patients are overdiagnosed as asthmatics. Many times they feel that this is asthma, that is why we are having labored breathing. So, so 30% overdiagnosis is there. Plus, it has been shown that 5 to 10% of their weight reduction leads to decrease in the asthma symptoms. So obese patients have the drawback that they are not very well responders to inhaled corticosteroids, and they do not generally show the typical picture of asthma. And weight reduction has been shown to show a positive change in the asthma response.
Right, which means to the extent that now even these GLP agonists have been mentioned in the GINA
GINA
2023.
guidelines, yes,
It's so
2020.
important that weight and these factors be kept a look at, because these are the patients. Dr. CVK sir, I would like to ask you that these means which are those who will exacerbate? What is the risk assessment for a patient developing exacerbation? Sir, unmute.
So I think Ravi bhai, very important thing is it is like in India, एक exacerbation if we are treating, okay, and the patient will come back to you, okay, imagine on an average, I am not generalizing, there are patients who come systematically, if you say 3 months once, 4 months once, they'll come and systematically they'll, get reviewed and then go back. But majority of times what happens is, if you give one prescription of acute severe asthma prescription, then eventually they may use at least 5 to 10 times before coming back to you for a real acute severe exacerbation. So this is what I believe that is happening as a ground reality. And these are the patients, okay, if they have had a previous exacerbation, they tend to exacerbate more. If there is a baseline lung function is low, example, if you even have around 30%, 40%, the chances that, this patient may come back, may exacerbate more. And then those patients who are using relievers more often, okay, you don't believe probably 4-5 months back, one patient have come, was using a only blue inhaler since 20 years. This is not uncommon. This is not uncommon in India. And then very poor inhaler techniques. So these are the patients where they tend to exacerbate, but again, and if we can't identify them, we are missing the boat. We should identify them. And then extra that 2 to 3 minutes of counseling in our busy OPD schedules, okay, probably can bring impact. But at the same time, these patients who are very rigid to change, we have to tell in every visit, whenever they are visiting, that you are at risk of higher exacerbations. Please ensure you follow your pulmonary function tests regularly. If not with me, at least some pulmonologists, because there may be no time constraint, there may be constraint with location. So, but they should follow the pulmonologists very closely.
Right, sir. Very important, because these are those patients in which we frequently come across them deteriorating and not improving. Ultimately, they come in problems. So, why is this important and how to manage it more effectively? Dr. Stuti, tell me, how do we properly assess a patient's asthma control?
So still, there are two components. First is the symptom control, and the second is the future risk of adverse outcomes. And another component is the future risk of exacerbation that sir has already taken. So the symptom control, there are multiple scores, ACQ, ATQ, but I like the GINA one. It's like easy and anyone can use it. So basically, for the GINA assessment, we ask the patient, पिछले 4 हफ्ते में, in last 4 weeks, what all has happened. So if the patient had any daytime symptom more than twice in a week, if he had any nocturnal awakening, किसी भी वक्त सांस फूलने की वजह से उठना पड़े, you have to specifically ask if the patient is taking Astalin, Levolan, any SABA reliever for symptom use more than twice a week. And if the patient feels they have to limit their activity, like especially kids, if they avoid playing. So if the patient answers yes to one or two questions, it's a partly controlled one. And if it answers to more than three or more than three, then it's the uncontrolled asthma. So apart from that, there are some basic
Ma'am, okay.
You are going to have a poor asthma control. Like if the patient has low FE even, especially less than 60% at the starting, when you are, or if there's a very high bronchodilator reversibility, like in the tune of 20-25%. If the patient has a lot of psychosocial issues, like we see a lot of patients suffering from depression and anxiety issues, panic attacks. Then, if we have been able to guess the eosinoblast sputum is blood eosinophil levels, high PNO markers, and if they have ever had an exacerbation, like even a single history of severe exacerbation in last year or as intubation, requirement of intubation, these are the ones which will be poor high risk factors for poor asthma.
Okay.
And we can also see if there are risk factors for persistent airflow obstruction. So if there's a preterm birth, so these have also been common COPD etiotypes also. Preterm birth, if there's a greater infant weight gain, if the patient has never been on ICS or is overusing SABA, if the patient has ongoing exposure to tobacco, noxious elements at the uh, workplace, or if the patient is in the lot of exposed to a lot of pollution. I mean, you can say this and 10 people come and say, then what can we do about it? But this is there. So these are the factors which are risk factors for persistent age.
Right. Very, very correctly told, ma'am. Then these ACQ and ACT are few objective ways in which, if we keep on assessing our patients in them, then we find it really easy to even suggest these patients biologicals in the near future if we find that they are continuously uncontrolled with the conventional modes of treatment. So, Dr. Nishtha, I would like to ask you one thing, that there is this thing of the patient's asthma being uncontrolled, or maybe the patient having severe asthma. So, how to distinguish between the two?
So the patients who have uncontrolled asthma are the ones whose symptoms are not controlled, as has just been mentioned, one, and second, or they are having exacerbations more than twice per year, that is requiring oral corticosteroids. So these are the patients that are basically not controlled. So uncontrolled patients need to be stepped up in the regime. And when we step up and we put these patients even on the highest ICS formoterol combination, and still the patient is not responding, then that patient becomes a difficult to treat asthma. Then that difficult to treat asthma patient, if we correct, majority of these patients have hidden some or the other hidden mistake. For example, whether the patient is not adherent to his treatment, the patient is not taking inhalers properly, there are other underlying comorbidities that are present. So there are many these questions that needs to be corrected and addressed. And if still after correcting all these factors, then also the patient's asthma remains uncontrolled despite high dose of inhaled corticosteroids, formoterol combination, and that is the time when we have to label the patient as severe asthma.
Right.
Now, the fraction around 24% of asthmatics remain uncontrolled. Then, when we step the treatment up, then the difficult to asthma becomes around 17%. This is the data that is published in JINA as well as taken from the Netherlands study that was previously done. And then uh, finally, the number of fraction of patients that are actually having severe asthma goes down to only 3.7%, less than 5%. So we need to correct all these factors before labeling a patient as severe asthma.
Right. So means we need to comprehensively evaluate somebody's practices, his advices, rule out other conditions, confounding factors, inhalation technique most importantly, and then only go ahead to label them as severe asthma. So in that, one very primarily important thing is communication. So Dr. Yash, please unmute yourself and tell me, what are the communication strategies for healthcare providers in managing asthma? Yes, Dr. Yesh, one thing I'll tell you, 9:30 बजने वाली है, 20 क्वेश्चन और है, इसने मेरे सारे पैनलिस्ट थोड़ा जल्दी करो.
So I think this is one of the most challenging part in treatment of asthma, to be really honest, because it is difficult to, first of all, to convince patient that he has asthma, to ensure that he is taking his inhaler properly, to ensure that his technique is proper, and to ensure that the patient comes back to you when you say the word asthma and the use of inhaler, and that you are not going to be habitual to the inhaler and everything. So all these are very difficult things to manage, but most important is that you be clear with the patient. You have to be very clear, very thorough while explaining that this is something which is absolutely treatable, absolutely controllable, that the patient can live his normal life, can continue his regular exercises when he if he's taking his medications properly, as well as with the treatment of associated comorbidities, allergic rhinitis being the most common one that is usually undertreated by us as pulmonologists.
Right.
So it is very essential that we communicate to the patient that okay, you have asthma. It's nothing to be worried about. It is nothing that cannot be treated. And we be very frank, answer all the patient's questions very calmly, make sure that the patient is really satisfied with whatever you are saying. And if necessary, keep a separate staff or maybe a trained RMO doctor with you who will be able to answer all the queries of the patient, so that the patient is really satisfied when he's leaving your office. So and check the inhaler technique, teach the inhaler technique, always keep a placebo sample at your table so that you are the one who's teaching and not some other staff, so that you are assured that the patient is really understanding what you're teaching him. And checking the inhaler technique at every visit, communicating to the patient that you need to bring your inhaler at every visit, and cleaning of the inhaler device, maintenance of the inhaler device, everything should be very thoroughly, clearly communicated to the patient. And making sure the patient knows that the therapy might go on for a few years, and in some cases lifelong, might be lifelong, but at least for a few years, and making them realize that okay, this is a chronic illness, but it can be really controlled very well.
Right, very, very beautifully answered. And it's very important to take out the fear factor of asthma in the patient's mind. And regarding, you yourself demonstrating placebo, भाई आप 50 मरीजों को placebo कराओगे, बीच में आप जरूर gargle कर लेना. Because by the end of the day, you end up with a stuck up throat. That is
Yeah.
very important. CVK सर नहीं करते थे, इसीलिए कई बार उनका गला बैठ जाता था. नहीं तो सर बहुत अच्छे गायक थे. So, Dr. Rubeena madam, tell me one thing. What is the long-term goal of asthma management?
Goal that we all of us we target at is improving the lung function of the patient, preventing exacerbations, the quality of life, and minimizing death caused due to severe asthma, and making the patient aware that yes, emergency management is always available, and also teaching the patient at home that these are the ways by which at least you can manage yourself at home and then you get that grace period to come back, come to the hospital and treat yourself. So basically, it is about assess, adjust, and review about the patient. So we need to assess the patients about the symptoms, the risk factors, then adjust the dose patient as per the requirements and whatever the results have come after the spirometry or peak expiratory flow, whatever. And then review the patient every time when the patient comes, that whether, like Dr. Yash already said, that whether the patient is taking the medicine properly or not, the inhalation technique is fine, and the patient is adherent. And most importantly, a very practical point that I want to point out here is that in my practice what I get to know कि बराबर वाली जो पड़ोसी थी हमारी, उसने हमको बोला कि ये तुम दवा लोगे तो इसकी आदत हो जाएगी. So we have to be very particular about answering that question कि it is not a habit forming, like you take your diabetic drugs, you take your hypertensive drugs and other medications. So this is one of the medications that make your lung breathe with you.
Right. Very nicely answered. वो आदत वाला क्वेश्चन तो यूनिवर्सल है एंड रियली इट इज इट शुड बी पार्ट ऑफ जीनो 2027 कि ये आदत का क्या किया जाए भैया. Then so Dr. Ishani ma'am, tell me the asthma management cycle for personalized care. हम उसको individualize कैसे करें?
So the asthma management cycle involves 3 steps. First is assess, second is adjust, and third is review. So first we need to assess whether we first need to ensure the diagnosis, whether the diagnosis of asthma is correct. Then we should consider the comorbidities, risk factors for exacerbation. We should check the inhaler technique. We should address the compliance, check whether the patient is taking in compliant to inhalers. Then we need to adjust the doses of inhalers, adjust, up titrate or down titrate the doses of ICS and other inhalers. And we should also check the technique and correct the technique. We should motivate the patient to ensure the optimum compliance. Then we should also uh, pay attention to other comorbidities and address other comorbidities like rhinitis, obesity. We should also advise upon vaccination and uh, rehabilitation. Then we need to reassess the symptom control, reassess the risk of exacerbations. We should also consider the side effects of the ongoing treatment. We should get a PFT done, and then this cycle needs to be. This is an ongoing cycle which needs to be considered again.
Right, right. Very correct. Very correct. And that is why, with such a lot of amount of medication available, what Dr. Ishani told becomes very important, that that cycle needs to continue. But Dr. Nishtha ma'am, tell me, how do we choose between the several available controller options which are available in the market for individual patients?
So many medicines and many combinations are available, but we need to stick with what Gina says because that is backed by evidence. And so Gina has divided its treatments into track 1 and track 2. Track 1 is the one that is the preferred option where the combination of formoterol is being used with inhaled corticosteroids. This is the preferred route. Why? Because it has been shown to be having the lowest amount of inhaled corticosteroid requirement for the patient. And so, and in case the patient is not responding or due to any other reason, we are not not able to give formoterol inhaled corticosteroid combination, then we can go with track 2, that is SABA or controller medication, that is LABA and inhaled corticosteroid, any form of LABA.
Okay. Yeah, quite right, ma'am. So, those who get controlled with this are good enough. But we know with the status of inhalation therapy, our advice and the person following it. So comes the question of oral corticosteroids. So one thing which I like the word which they used is OCS to stewardship. One very unique word. Dr. CVK sir, tell me what are your these views about this word that Gina 2026
Stewardship
says
of
OCS?
OCS. So definitely it is very important thing. So at least they coined the term of stewardship. Okay, simulating probably antibiotic stewardships that what we are practicing day to day life in critical care. So what is important is we all as a responsible physicians we need to understand OCS usage is harmful. Unless it is mandatory, we should not use. And then if it is mandatory also, we use, and then we should try to bring the OCS usage to as minimum dose as possible at the earliest, because there are asthmatics who are steroid dependent. For them, if you don't use, that's a crime. And then if you use at a very inappropriate dose, that is also a crime, because these are the patients where they may land in, significant side effects of steroid usage like diabetes, hypertension, osteoporosis, cataracts, glaucoma, obesity, adrenal suppression, infections, mood disorders, gastroesophageal reflux, myopathy, cardiovascular risk, so many and so many. You can write a book on it. But at the same time, it is our duty as a responsible pulmonologist, we should try to minimize the usage of and then prescribe the dose which is exactly required to the patient. Point number 1. The moment we are contemplating usage of OCS, we should also parallelly think and start counseling, because those were the era, probably 5 years back, we have only one biological, that is omalizumab. Now we have mepolizumab, benralizumab on special permissions we can get. We have patients on dupilumab and tezepelumab as well. That's the reason it is very, very important that we should consider using biologicals as well, and then counsel them accordingly. Modern asthma care, as per 2026 GINA guidelines, it's not just about controlling symptoms, it's about controlling steroid toxicity as well. Over to Ravi Bhai.
Right, quite right, sir. Very importantly, now I know there is a dearth of time, but Dr. Nishtha, you just told about controllers, several options. You mentioned about tracks. Can you also guide us on the several asthma treatment steps which are there?
So GINA has before also and now in 2026 also divided the treatment into track 1 and track 2, and both tracks are divided into 5 steps starting from 1 to 5. So if we talk about the track 1, the track 1 is basically in which where formoterol as well as inhaled corticosteroids is the anti-inflammatory therapy that is being used. And here the reliever is also the combination of formoterol as well as inhaled corticosteroids. Steps 1 and 2 are merged together, where low dose inhaled corticosteroids, formoterol is being used as a reliever, and no maintenance therapy is being given. While if we talk about the 3, 4, 5, the same formoterol and inhaled corticosteroids is being given as a maintenance therapy. Only the dose of the inhaled corticosteroid varies from step 3 going towards step 5. In 3, it is low dose, and in 4, it is medium dose, and in step 5, it is high dose. Similarly, when we talk about the track 2, in step 1 and 2, inhaled corticosteroid is given as a maintenance, with SABA given as SOS therapy, as well as when we talk about the 3, 4, 5, the concept is the same, where the inhaled corticosteroid gradually upstages from low dose to medium to high dose. Only in the track 2, formoterol is being substituted with other LABAs. And each patient, when we are starting the therapy, we keep the patient on a single step for 2 to 3 months. Once the patient stabilizes, that is the time when we need to step down the therapy. And in case the patient still remains uncontrolled, that is the time when we step up the therapy.
Right. Very crisply and nicely answered. Now, I know my other panelists are getting impatient, but Dr. CVK sir, this is GINA's this year's headline. You should prescribe anti-inflammatory inhalation therapy to every patient. Tell me why.
See, that is the crux of GINA 2026. So, whatever symptoms, asthma symptoms, hitherto we used to manage based on symptomatic control. But now it is very clearly understood that those who use relievers without inhaled corticosteroids, they tend to have a lot of side effects. And then Nishtha was clearly mentioning, if globe is losing 100 asthma patients, out of which India is losing only more than 50%. So that is the crux of the problem. It is our important duty to take this message of usage of anti-inflammatory relievers, that is inhaled corticosteroids, should be prescribed from the day one of asthma diagnosis. And then this helps in, prevention of remodeling airways and then development of fixed airway obstruction. So unless we control from there is some saying in Telugu, I must tell you, those who are Telugu listeners, Mokkai vanganidi mane vanguna. What it means is, when you cannot shape a plant, when it becomes into a tree, it is very, very difficult to mold the plant according to your requirements or tree at the stage of tree. So that is, you have to take the shape of the airways into inflammation free, not the bronchospasm free. Inflammation should be relieved, airway remodeling should not occur, for which inhaled corticosteroid reliever-based reliever therapy is mandatory. That's why formoterol budesonide combination has become the standard of care through 2026 guidelines onwards. Anti-inflammatory reliever smart therapy is a choice. Please, friends, whoever listening, ensure that even the patient is having mild symptoms, start them on anti-inflammatory reliever therapy.
Right, quite right, sir. Quite right. Dr. Yash, tell me now, in several patients, how do you decide? Just give me a crisp answer, choice of medication, device, and dose. Just how do you quickly do it?
So I think Dr. Stuti in her talk has beautifully covered this already. So we have the ones available in India are the emitter dose inhalers, dry powdered inhalers, and the nebulizers. So each has its pros and cons. MDI is something which is very familiar to everyone, but it requires a good coordination between the release of the dosage and the inhalation that the patient takes. A dry powder inhaler, there's less issue with coordination, but the patient requires a good inspiratory flow so that the medication goes in completely and reaches the peripheral parts of the lungs. Whereas nebulization, so there's no issue of coordination with nebulization, but as Dr. Stuti has had mentioned that using a mask that is nasal route of inhalation is associated with lower deposits to the lung as compared with the using of a TPs and a oral route for nebulization. And it is more time consuming because the neb goes for typically 10 to 15 minutes and definitely more expensive as compared to the other two devices. So it all depends on the patient's financial status, the patient's ability to take the device, and the patient's inspirator flow rate and the patient's ability to coordinate with the inspiratory effort.
Right, right. Very nicely told. And yes, Dr. Stuti, you have covered it very elaborately in your presentation, which can be accessed by everybody on the CCI's YouTube channel. It will be there as a ready reckoner always. Dr. Stuti, modifiable risk factors in asthma management. Quickly, will you tell what are those factors we should look at?
So I'll talk about it very briefly. So first of all, if the patient is smoking anything, hookah, bidi, cigarette, vaping, e-cigarettes, whatever it is, they have to stop it. If the patient is obese, we have to guide them about the lifestyle management. And now we have multiple drugs which are available, and with the semaglutide coming in the generics as well, I hope most of the patients will be able to tolerate it as well. A very important topic which is close to my heart is the major psychosocial issues that the patient might be facing. I mean, we really need to work on it with a psychiatrist or a psychologist. A lot of the, especially female patients, might be having these issues, and it might make these panic attacks, anxieties, which maybe at times it may be difficult to differentiate, and they also contribute. Confirmed food allergy. Yes, the patient needs to be taught about the EpiPen, about avoiding the drug, and especially in the when they are going out, when they are outside the country. And although it is not very commonly picked, but if the patient is having an ongoing occupational exposure, every effort should be made to identify it and to try to relocate the patient as earlier as possible.
Right, right. Very, very correctly told. One very important modified risk factor is indoor allergens. Dr. Rathi, please आप बताएंगे how to advise about these avoidance of indoor allergens.
Very quick about it. We have like common indoor allergens, house dust mites, and cockroaches, rodents, pets, and fungus. These are the common allergens that are present in our houses. And to avoid that, we should be using the HEPA filters, vacuum cleaners with HEPA filters, and washing the bed linens with hot water, and avoiding the pets. Till the time we are not pet friendly, we can anyhow avoid the pets, and we can manage the rodents also with different like different strategies. Different pest control companies help us with that. So these are some common ways, and a good illuminated house with sunlight is one that um, is always a positive thing that helps us in avoiding the indoor allergens.
Quite right. So tell me one thing, Dr. Ishani, weight reduction, several of our panelists have told, weight reduction in asthma, it is becoming so much more important. Anything you would like to throw light on?
So, as we previously discussed, asthma and obesity, this combination is very difficult to treat because of the different airway inflammatory GERD, OSA, and the reduced chest wall compliance and suboptimal diaphragmatic position all are the contributory factors. And even as this previously discussed, even 5 to 10% of weight reduction will offer benefits in terms of asthma control, reduction in exacerbations, and improved quality of life. Bariatric surgery has shown marked improvements in all these parameters. However, we should consider the surgical fitness when bariatric surgery is being planned. So we should get a PFT and a sleep study done. Then with GLP agonists like semaglutide, liraglutide, these are promising agents coming up. But with all the noise about these wonder drugs, it is associated. They are associated with serious side effects. So it should be uh, taken by the prescription of a specialist. Then lifestyle changes are the backbone of weight reduction. Any weight reduction strategy, prioritizing protein, prioritizing fiber, anti-inflammatory diet, intermittent fasting regimens, then um, strength training, aerobic exercises, all needs should be it should be a comprehensive approach towards weight reduction. Also, the weight reduction should not be rapid; it should be slow and sustainable. CPAP therapy in case of obese patients with OSA will help in better symptom control and
Quite right, ma'am. So I think she has very nicely answered this question. I would like to ask Dr. Rubeena your comment on vaccination. Is there any point in vaccination? Although, could you keep it crisp and tell us, please, how it will help?
Gina, if you go with it, so they have added RSV vaccination along with that. Influenza and vaccine are one we should look for, and DPT. And the children vaccination history that becomes very important. So influenza vaccine every yearly and vaccine every 5 yearly. RSV and DPT boosters that should be taken into consideration every time when we go for any of the respiratory patients, not only asthmatics, be it ACO or COPD patients, any of IRD cases, we should consider with the vaccination and along the comorbidities. If patient is coming up like diabetes and hypertension or obesity, we should try to convince them. Although still I'm finding it very difficult to convince the patient for vaccination because elderlies are the uh, considered family don't consider that it is worth spending on them. So still it is still difficult, but definitely like COVID has changed so many things. In a near time, I think vaccination will all is going to be increased in that population that we really need.
Quite right. So I think that is very important. Now, just a quick comment I would like from Dr. Stuti. Tell me, non-recommended bronchodilators, किनको कभी नहीं हमको advise करना. Could you comment on that?
First of all, is phenobarbital. I mean, thankfully, it is not available in India. I think the only name I can found was Buroport in which is being marketed by Boehringer Ingham. It's not available in India. Other things are very prevalent in villages are the oral ephedrine, oral SABA tablets. These are the ones that have to be avoided. And any combination without ICS, like anticoagulants, patients just on ipratropium, patients just on Libolem, which is the overuse of SABA, this has to be avoided. These are the ones.
Right. So I would just like to call upon Dr. Nishtha to tell us, is there any actual role of OCS available now? जो OCS stewardship की Dr. CVK ने बात करी. So any OCS role is actually there in management of asthma?
only in those patients who are not responders and who are actually having severe asthma before we start the patients on biologics. And I believe that is the only segment. And as has already been discussed, that GINA 2026 has made it really clear that, and they have used this term also, stewardship, and they have put this stance that oral corticosteroids are not supposed to be used at all, only in cases when inhaled corticosteroid fail and any other therapy is not available.
Quite right. So managing asthma, chest physicians को भी भूख लगती है. So CVK sir, last question for you. This combination ICS, SABA and all. Now this we know there are several studies noted. Batura and best studies have been noted in GINA 2026. Please sir, your words of wisdom with your final comment I would like on this particular ICS SABA thing that has been proposed.
Yeah. Ravi bhai, thanks for this last question. So after that, I would love to give a conclusion statement as well. So what is this Batura study, which we should all go home with this take home message? It was studied among the poorly controlled asthma patients, and one group they have given ICS SABA, and then either alone or as a reliever for patients taking daily inhaled corticosteroids or leukotriene receptor anti, that is Montelukast. So when it is studied along with SABA as a reliever alone, so anti-inflammatory reliever therapy that is done with inhaled corticosteroid plus SABA, when it is checked, it is shown that it is reduced the overall severe exacerbation by roughly around 50%. So in an asthma patient, the key aim is to reduce the exacerbation, and then when a reliever is combined with inhaled corticosteroids, SABA plus ICS does wonders by reducing more than 50% exacerbation. That is the take home of Batura study. Over to Ravi bhai.
Right, sir. Thank you. So your final comment also is the Batura study. I think that everybody go through the Batura study. So, sir, anything more you would like to add? That's
no, I want to add, since it is World Asthma Day webinar, so what is effectively, in GINA 2026, okay, what we should remember. So I try to make a mnemonic. So World WORLD Asthma Day D. So just it may take 60 seconds. So W for wider push for anti-inflammatory reliever. We discussed oxygen threshold. Okay, unless the patient during severe exacerbation, if it is crossing less than 92%, you need not support with oxygen therapy. And then reduced SABA aggressiveness. It is very bad habit that is spread across the subcontinent like a wildfire, that whenever there is an exacerbation, you prefer SABA alone, but combine, you have to reduce. R means reduce SABA aggressiveness. L means lung function documentation is stressed. FE1 or PFR has to be monitored. And then World WORLD discharge planning becomes central. Every exacerbation requiring OCS or ER visit treated as a red flag, and structurally follow-up recommendation is maintained. And then the 2026 GINA guidelines reiterated that. And air therapy, anti-inflammatory reliever therapy is also extended to children alone. And then budesonide formoterol combination is approved for even children between 6 to 11 years age. And steroid stewardship is highlighted, and technique matters more than ever. And holistic assessment tools like CAT tools, PEDS, AirQ tools have been incorporated. MART, again, maintenance and reliever therapy has been stressed. anaphylaxis integrated into asthma algorithms, and last but not least, depemokimab. Okay, this one thing, the guidelines clearly says that those who are mepolizumab responders, okay, they can be changed to depemokimab. Okay, this can be given twice in 2 injections in 1 year, every 6 months once. So that's how the biological burden of taking, monthly once or alternate months can be reduced to just 2 injections in 1 year. So just to summarize, World Asthma Day. So wider AIR therapy, WHO oxygen targets revised or reduce SABA dosing, L lung function stress, D discharge summary planning, and anti-inflammatory reliever in children, S for steroid stewardship, T for technique emphasis, H for holistic asthma tools, M for marked strengthened, A for anaphylaxis algorithm included, and depemokimab biological availability in 2026 guidelines.
Great, sir. Amazing. So, very nice, sir. Dr. Nishtha, your final comments, please.
So I just want to thank CCI team and Vijay sir and you for such an excellent moderation and giving such comprehensive questions on asthma, starting and covering asthma in the whole entity. So I wish everyone a very fulfilling year with good asthma control, and may God give us strength to treat and diagnose our asthma patients correctly and timely.
Wow, very nice. Now, Dr. Ishani. Dr. Ishani, your final comments, please.
Spreading awareness about asthma, then reducing the stigma associated with asthma and inhalers, prioritizing anti-inflammatory inhalers, and proper inhaler technique. These should be inculcated. Basically, this.
Very nice. Thank you so much. Dr. Ruby ma'am, your final comments for all of us, please. Any take home?
I'd like to really thank you and the entire CCI team for this crisp China 2026 guidelines. And it was really difficult to compile everything in this timeline. And still many things are left. Hope we'll be doing it in the next session and the next webinar. So I hope everybody is going to treat it well, and we are able to treat our patients and satisfy them with the holistic approach that what Vijay sir already said, that treat it with a holistic approach.
Yeah, very
And
nice.
yes, stewardship is one very important thing that we all should keep in mind.
राइट बट मैम एक बात बोलूंगा, अगर 2 घंटे क्रिस्प है तो पता नहीं फिर व्हाट आर यू एक्सपेक्ट. बट वन फैक्ट है कि CCI will also be having a subsequent webinar on severe asthma, and CVK sir will also be part of that. ये मैं पहले ही बता देता हूँ. So coming to Dr. Stuti ma'am, please your final comments.
I think my final comment will always be please check inhaler technique. Whatever you have given, just check the technique.
Right. So very nicely, I would like to thank all of you. It's been comprehensive, but that is the way I feel. Stable asthma has lot of things to mean. Stable asthma naam ka hai, but really that is what the bread and butter of any pulmonologist is nowadays. We need to discuss it comprehensively, and I hope sincerely that, and I know that all of you have done a lot of justice to it. It's very late, but we are still discussing it, and that proves it a point that asthma has so many facets and so many aspects that we need to be very comprehensive when treating the patient. And the fear factor of the patient is one thing which I feel is paramount, that has to be removed. Any negativity associated with has to go, and things have to be done logically, scientifically, and properly. I would like to wish all of you on behalf of CCI a big good night. I would like to thank our team Cipla, our technical team, for the excellent coordination that they have done. On behalf of all panelists and myself, Dr. Ravi Dosi from Indore, I would like to wish all of you a good night and thank you for participating.
Wonderful.